let me introduce my PhD thesis, fertility-sparing treatments in gynecological cancers. Oh, and I have this. Okay. So, let me start with a quick summary about my first project. Cervical cancer affects many young women. For tumors under 2 centimeters, fertility-sparing surgery is safe and effective. But for tumors above 2 centimeters, these cases require more radical surgery. That's why current guidelines don't recommend fertility-sparing treatments. The radical surgery reduces pregnancy rate to just 8%. A systematic review, a meta-analysis, found that although upfront surgery is safe, adding neoadjuvant chemotherapy could shrink the tumor to allow a less radical surgery, increasing pregnancy rate to 31%. All right, so because of that, women who wish to maintain their fertility should be offered this combined approach, neoadjuvant chemotherapy and surgery. Our findings based on observational data, this highlights the need for more prospective trials and shifts the treatment for a patient-centered care. My name is Ádám, Vincze. My supervisors and I would like to live in a world where women can keep their ability to reproduce even after the appropriate oncological treatment. We want to achieve that through finding the best fertility treatment options for gynecological cancer patients. We have 2 specific goals in mind. The first one, which I already summarized for you, is titled Investigating the Efficacy and Safety of Fertility-Sparing Treatment in Early-Stage Cervical Cancer above 2 centimeters. Cervical cancer is the 3rd major cause of oncological death in women. 40% of it is diagnosed in the age frame where fertility preservation is key. Fertility-sparing surgeries like colonization and trachelectomies are oncologically valid alternatives to hysterectomy in those cases where the tumor size is below 2 centimeters. However, when the tumor is bigger than that, the upfront surgery reduces the pregnancy rate dramatically. The idea is that with the help of neoadjuvant chemotherapy, we could shrink the tumor and potentially downstage it for a less radical surgery. Our aim to find an oncologically safe and fertility-wise sufficient fertility-sparing treatment for these larger tumors. We have a PICO framework for that. The question is which treatment is the best for these women who have these larger tumors and the intention to maintain fertility. We're investigating neoadjuvant chemotherapy followed by surgery and compared it to upfront surgery. The outcomes we're interested in are oncological and fertility ones, and according to our hypothesis, the combined approach provides better oncological and fertility outcomes compared to the upfront surgery. Our search key consists of 2 domains, the first one about the disease and the second one about the treatments. Among 3 databases, we found around 12,000 hits, and after a careful selection, we arrived to 19 eligible texts. We're currently at the manuscript writing stage, and let's jump into the results. This slide shows the forest plot of the pregnancy rate, and pregnancy rate is a great outcome to assess fertility. It shows the proportion of treated who could become pregnant. The scale goes from 0 to 1 or 0 to 100. 100 is, of course, the desired outcome, meaning that everyone could become pregnant. 0 means that no one could, just like after a hysterectomy. It's important that both our investigated approaches preserve the uterus, preserve the childbearing potential. The question, which one is better at it? The analyzed cohorts contain around 50 and 200 patients from 3 and 14 observational studies. The heterogeneity was I-squared 0% for both cases. However, the confidence intervals of the I-square for both cases was quite wide. The sources of heterogeneity comes from the small patient number, the low event number, and the fact that some women, after a successful treatment, decided not to have children at all. The pooled pregnancy rate for the upfront surgery was 8%. For the combined approach, it was 31%, meaning that 8 and 13 people out of 100 could become pregnant. This shows that the combined approach have a fertility So it's a better fertility after treatment compared to the upfront surgery. All right, and it seems more efficient, but is it safer as well? To answer that, let's jump to the second forest plot. It shows the recurrence rate. Recurrence rate is a crucial metric to assess oncological efficacy. It shows the proportion of treated who experience a relapse. The scale now, the desired outcome is 0%, meaning that no one relapsed. 100 would mean that everyone did. The same population after hysterectomy would experience below 3% recurrence rate. The prior articles supplemented with 2 new ones resulted in a larger sample size, around 130 and 200 patients. The heterogeneity was I-squared 0% as well, and the sources of the heterogeneity remained the same. The pooled recurrence rates was 10% for the upfront surgery and 13% for the combined approach, meaning that 10 and 13 people out of 100 relapsed. There is no statistical difference, significant difference between the approaches in recurrence rate, but there was in pregnancy rate. That means that we should offer the combined approach for women with these larger tumors who decline the guideline-proposed hysterectomy. Our study strength lies in filling the literature gap by providing evidence on fertility-sparing and focuses on this highly specific population without the influence of additional treatments. It has limitations. I just mentioned the high heterogeneity and the fact that we used observational single-arm studies. So we can say that based on our currently available data, neoadjuvant chemotherapy followed by fertility-sparing surgery may lead to higher pregnancy rates without compromising oncological safety compared to the upfront surgery. This has implications for practice. This overlooked population now are provided evidence on fertility-sparing. It challenges the conventional fertility-sparing criteria and promotes a personalized management that respects patient priorities. Implication for research that we need more prospective data about this to strengthen the level of evidence. I just mentioned as well that the manuscript is currently under working, and our target journal is gynecological oncology. And I just want to mention my second topic, investigating the efficacy and safety of fertility-sparing treatments in atypical hyperplasia and endometrial cancer. Endometrial cancer is the 4th most commonly diagnosed cancer with a rising incidence rate. 4% of it is diagnosed in an age frame where fertility preservation, again, key. Atypical hyperplasia is a premalignant condition that's treated in a similar manner. Guidelines are the same in that the first step should be hysteroscopic resection, followed by either oral progestins, IUDs, with or without metformin. So these treatments can vary in their risks and benefits. For example, hormonal IUDs contains less hormone, but there's a risk of uterus perforation during application. Our aim to find the best fertility-sparing treatments for these cancer patients. The question is which one is the best? The investigated population, again, atypical hyperplasia or endometrial cancer, patients who undergone the first step, the hysteroscopic resection, and we're investigating oral progestins, IUDs, metformin, and their combinations. According to our hypothesis, the combination of the 3 of them provides the best results. This study can potentially highlight the differences among the treatments. So in summary, we have 2 ongoing projects, the first one about cervical cancer, the second one about endometrial cancer. And I would like to finish my presentation with a quote from Marcus Aurelius: "Is the truth I'm after, and the truth never harmed anyone. What harms us is to persist in self-deceit and ignorance." Thank you so much.
Thank you, Ádám, for your nice presentation. I would like to ask another question, but relating to your lecture. I've been to latest update in the obstetrics and gynecology, and I heard about the uterus transplantation.
Oh, yeah.
So is it the next possibility after the fertility-sparing technique, or it's only a vision?
That's an option, of course. So my studies not include that as an option, but I heard that in Hungary as well we are trying. Actually, I think it's Page that trying to prepare for the first uterus transplantation. I believe that it's a promising approach. Of course, for cancer patients, it's rather difficult to talk about transplantation, but I think it's an option for the future as well. Thank you.
Please use the QR code to evaluate the colleagues. And only one question. So do you have a guideline for the neoadjuvant chemotherapy? And how does it look like with overall survival?
Yeah, so current guidelines in the EU, it's stated that it's only like in a clinical situation you can use the fertility-sparing options for these women. In the US, they stated that in specific characteristics you can go along on the fertility-sparing approach. So guidelines are not that well developed, but the neoadjuvant chemotherapy usually are cisplatin and paclitaxel. So this is the main.
And you are using this kind of neoadjuvant chemotherapy, and you would like use it for these patients also, and that's why you are performing.
Yes. So the idea is that with the help of neoadjuvant chemotherapy, the tumor size reduces dramatically, and a less radical surgery is enough to operate to air null, and that's why the pregnancy rates should be higher in those cases.
Because I was just wondering that you give some chemotherapy, and the fertility will be better than without chemotherapy. But if it's working, then I'm very happy, and you can give it to your patients. So thank you very much for your questions and for your presentation.
Yes. I have one question. Sorry.
It's okay.
I really like your question to me, so I'm asking the same question to you. When after this fertility-sparing surgery do you suggest getting pregnant to this patient?
Oh, you mean like how many months should I? In a couple of articles, they said that they waited 3 to 6 months after surgery. That means that even if they get chemo, then they get the surgery, and after 3 or 6 months, they can start to conceive. Yeah, try to conceive. Okay.
So, hi, nice progress and person in general. So my main question would be, you mentioned the main limitation is heterogeneity, but if the I-square is 0 and if it's a very specific population, then
all right. So
then why is it a great limitation?
Thank you for your kind question. So I-squared is 0, but as I just told you, the confidence intervals of the I-square was rather wide. That means that we can't really state that the heterogeneity is low, because, you know, when the confidence interval is 0 to 90, that's basically nothing. I already mentioned the sources of heterogeneity. We will try to add more subgroups maybe to get an idea of why is that.